To start introducing Dr. Aidan Cashin. He is a NHMRC Emerging Leadership Fellow. Aidan worked clinically as an exercise physiologist before completing a Ph.D. in medicine from the University of New South Wales. Aidan's current research focuses on investigating the mechanisms of healthcare interventions for optimization and translation into clinical practice and healthcare policy. Most of his work is applied to the management of chronic musculoskeletal pain conditions. Aidan also conducts methodological work that aims to improve research transparency and openness. He is a full-time research fellow at the Centre for Pain Impact, Neuroscience Research Australia, and an associate lecturer at the School of Health Sciences, the University of New South Wales. So please welcome Dr. Cashin.
Bit quiet. Oh, that's quite loud. That sounds better. Thank you. Thank you for the introduction. I apologise in advance for my accent. It's strong and it's excitable, so I apologise for that. Thank you for this opportunity. Thank you for staying. Thank you for those online tuning in. I know it's tempting to go to the bar, to catch a plane or do anything else, so I appreciate you hanging in here with me today. Before I begin, I just want to really thank the other speakers who have presented today. Thank you to those who've shared their lived experience. I don't think I've felt that many emotions at a conference before. It's been really powerful. Thank you for the researchers who've shared your research and your research journey. It's really excited me, and it's also helped set the stage, I guess, for some of the things that I'll talk about today. I'm going to try not make it too serious and too intense because it is 4:30, 5 o'clock in the afternoon, so we want to take it a little bit easier. And luckily the speakers before me today have done a really good job introducing some of the key ideas that I think the research I'm going to present today touches upon. Earlier this morning, Tash told us a little bit about how perception arises and some of the insights around predictive processing and how it's not exactly what we first thought, and that's pretty important to the sort of work I'll talk about today. We learned from Lauren about mindsets. And I haven't used the term mindsets in my presentation today, but I think it actually is reflective of the way we view our problem of back pain, which I'll talk about today. So I'll try to touch on that. And even from Catalo later this morning, he spoke about the need for sensory and motor components of rehab to have a meaningful impact for people with phantom limb pain. So hopefully I can draw some of that together with a particular emphasis on back pain, which has been really my bread and butter research, as well as my clinical experience. So a few disclosures. I currently receive salary from the Australian Government's National Health and Medical Research Council. They pay my wage through a fellowship, and I've received project funding for some of the studies we'll talk about today from the Australian Government's Medical Research Future Funds. So for the next 45 minutes, I've got a timer, so I'll try stick to it. I'm going to talk about three main things. I'll talk about back pain as a problem, something which doesn't need too much introduction. I'm sure you're pretty well aware of it. But I really want to focus on one way of viewing that problem. A newer model, there's been lots of models, and this is another one, so I apologise for that. But this is a model which tries to make sense of the complexity of the back pain problem. Then I'll introduce a treatment, which we have named Greater Sensorimotor Retraining, which is developed specifically from the bottom up from that model. And I'll talk about an application of that in a recent randomised controlled trial we conducted, which was called the Resolve trial. Then I'll try to finish with some broader applications of how we can think about back pain more generally, but also maybe more generally to other chronic pain conditions. So like I said, my research is really focused on back pain, particularly chronic low back pain, is what I saw routinely in clinical practice, and it's what drove me towards doing more of a research journey and a research career. I'm interested in back pain partly because it's a big problem, not just because it's common, it's incredibly unpleasant, and it's really costly to our societies, but particularly because it's not well managed. And this is something that I see routinely, and I hear from people who have back pain that this is something they really wish they could have addressed. And one of the problems that's not particularly well managed is our available tools or treatments really only provide small to modest benefits at all. And when they do, the real challenge is they only provide benefits in the short term. People want long-term sustained improvements so they can get back to the things which are meaningful and important to them. And unfortunately, our current treatment arsenal is not providing patients with these opportunities. So this is something that's really been a bugbear of mine, something we've been trying to work towards. And one of the problems that maybe we don't have treatments which are providing long-term gains is because our current treatments are quite unimodal. They're only really trying to fix one potential driver of this complex experience. And I guess Bob alluded to this really quite nicely in his talk. And there's some accumulating evidence that back pain is complex. Bob really articulated that really quite well today. And it really involves some changes within the system that generates pain, which is possibly a key contributor and has really been overlooked specifically within our current treatment approaches. And the back pain field has really tried to rally together and have a call for action for new models and new treatments which better address the complexity and better meet the patient with what they want, long-term, clinically sustained changes. So that's kind of the problem that collaborators of mine have been really trying to address. For me in a short amount of time, but for my colleagues, Professor Ben Wand and Professor Lorimer Mosley, really been trying to draw at this problem for the last 15 to 20 years. And through their developing clinical and experimental data, they've tried to make sense of this complexity that we see in the back pain problem. And together they've put together a new model, which they've described as the fit-for-purpose model, which has really tried to build upon extending the existing models we have in our care already. And they've tried to integrate both cognitive and behavioural factors in addition to this new modifiable neuroimmune processes that we described as being maybe a key process involved in people's persistent pain. And a part of this model, as described, is really that it tries to target modifiable factors across the biopsychosocial spectrum. So it's not just trying to play at one particular focus, but trying to address a more broader lens. And I really want to pay attention to the idea of modifiable. This is developed to be a way to describe the treatment, a way to describe the problem, but also a way to identify treatment strategies. So we have to look at things which are modifiable, able to be intervened upon in order to think about how we can better help people with back pain. So a part of this model wasn't just to make sense of the problem, but also to try and develop some coherent treatment framework. And I'm going to go through one such application, but the idea is within this model that this could be applied to your current treatments, whether it's through massage, exercise, whatever you're currently applying, you can start to view your treatment framework within this new lens. So this is a paper which describes the model in great detail. It's a little bit dense. Ben loves words, he's really good at writing, and in this paper reflects that. So I'm going to try to give you a real short summary of it, but if you are interested, and I do encourage you, check it out. In the paper it presents this model. It's quite dense, to be honest, but it's actually a lot denser, less dense than the paper itself. And what it really tries to do is make sense of how a person begins their journey through care with back pain, and as pain persists, start to see changes which start to reinforce this, I'm going to call it a mindset, or this cognitive model of a damaged, fragile and unhealthy back. And all the information available to that starts to reinforce this idea that they're damaged and vulnerable. And there's kind of three key features which happen as pain persists or in this person's journey. So the person starts to develop this view that their back or their body is damaged and fragile and vulnerable. They begin to think that they're not fit for purpose. As the nervous system changes throughout the person's pain experience, we start to reinforce this internal model that they're damaged, they're fragile, they're not healthy. So the back doesn't feel fit for purpose. And as a result, from decreased engagement with meaningful movements and activities, they start to have decreased capacity and load tolerance. And as a result, their body is no longer fit for purpose. And this becomes some sort of vicious cycle which reinforces each other. And the paper, it talks about some of these changes that we see in people who have persistent back pain. And Tasha alluded to some of these, whereas a person with back pain has difficult identifying sensory information compared to their peers about back pain. We think that these sort of changes are contributing to this internal message, or this understanding that they're no longer fit for purpose. And that's the real problem we're seeing here, is this gradual reinforcement of all these ideas. But with any cycle, there's opportunities to break this with the intervention strategy. And that's what we've tried to really focus on with this model. It's a model to try and make sense of the complexity of the many interacting factors that occur in a person's back pain journey, but also try to identify what are some targets that we can intervene upon to get this person back on the road to recovery. And that's where the associated treatment framework comes from. So really, if we made it really simple, there's 3 key pillars that we think a good treatment to get someone back on the journey should be addressing. We should be able to help the person understand that their body is safer than it feels. We want to start to refine some of these neural networks so the body starts to feel safe to move. Then eventually we want to load the body tissue so the person can experience safety with movement and start to get back to the things that they want and need to do. So how do we help understand? This pillar is really focused on updating the person's internal conceptual models of their back pain and in multiple layers. And one of the key strategies we have to try and update our internal models is using education, specifically contemporary pain science education, which starts to reinforce some more adaptive and appropriate messages of the person's back, but also the pain system. And when we talk about education, it's not this simple didactic, me talking to you. This is more contemporary notions of learning where it involves experiential opportunities so the person can take that information, put it into practice, reflect and refine and continue to evolve. So it's more of a comprehensive educational experience. We want to use the refine pillar to start to normalise or retrain these neural representations. So there's different tools that we have within our tool belt. We have tactile discrimination training to try and improve some of the sensory information. We have both motor imagery and mindful body mastery exercises which are trying to sharpen up some of these motor representations and help the person start to feel that it's safe to move, start to prepare them for movement so that themselves as a person, as a body, is ready to start getting into the tasks which are important for them. And finally, we want the person to get back into things that they want to do. We start to load the body again, but we want to start with really trying to get them to do safe embodied movement experiences, as well as trying to use tools within our tool belt to minimise pain during movement and also try to progress them towards more goal-orientated and, I guess, meaningful and relevant tasks for them. So together, the whole idea of this framework is to help the person understand, refine and load. And as they go through each of these pillars, they're continually experiencing, consolidating this information to try and get themselves to a state where they start to feel once again that they're fit for purpose. So you might be thinking, well, how can I apply some of these ideas with my current clinical practice? I'm sure you may be targeting the understand pillar quite nicely in your clinic. Maybe you're already targeting the refine pillar, or maybe the load is one that you're starting to really work on. But it's starting to think of a way, well, how can I actually start to use the other pillars and make them work together to get this person back on their journey? But I'm going to introduce you to one such treatment which we've built from this model, which has really tried to purposely target each of the pillars. And the intervention is called graded sensorimotor retraining, partly because that's exactly what it's attempting to do, also because we can't think of a better name for the life of us. And this conversation has been happening for longer than I've been doing research. So it was first developed and tested by Ben Wand in a series of case series with 3 participants back in his lab in Western Australia. And it seemed to be acceptable to patients and it seemed to have quite impressive changes in their clinical outcomes. It was then taken to a small pilot randomised control trial from our colleagues Hanu from Europe, and also once again continued to show these promising signals. And as a result, we applied for funding from the Australian government to do a larger randomised control trial, and that's the trial I'll talk about today. So we've always called this the RESOLVE trial. I don't think it's ever called the RESOLVE trial in the paper. That's how we refer it to. So this was a test of graded sensorimotor retraining against a sham control in people with chronic low back pain. So I'll talk you through the trial and I'll put particular weight towards what the intervention was because it's a little bit complicated and a little bit strange. So I really want to make sure I give it justice and you get a rich sense of what actually it was. So the trial itself just wanted to estimate the effect of graded sensorimotor retraining, this new fit-for-purpose informed intervention, on pain intensity of people with chronic low back pain. So this was your classic randomised controlled trial. We had 2 groups. We had our intervention group, but our other group was a sham-controlled group. And I'll talk a bit about what that looked like and how we did that. It was conducted at a single centre, which was this building here, Neuroscience Research Australia. That's actually where I sit if I go to the office. It's quite a flashy research institute, so you can appreciate the feeling of the participants may have had when they arrived for their first and multiple sessions. We included the sort of people you normally would include in a back pain trial. We didn't exclude for too many reasons. The only one which is a bit unusual was we required people to have a trusted person to assist with the home training. So one of the elements of the intervention included the need for a trusted person. So that was an inclusion criterion and a bit of a tricky one for us. Otherwise, people with non-specific low back pain lasting for at least 12 weeks and rated at least 3 or more on a 0 to 10 scale. So we had two groups. We had the graded sensorimotor retraining group and the sham and attentional control group. Both groups received 12 one-hour one-on-one treatment sessions with their trained study clinician at our Shiny Research Institute in Sydney. These sessions were conducted over an 18-week period to try and allow for people to go on holidays or be sick and miss a session. And we also asked that people did additional 30 minutes of homework up to 5 times a week. So it's quite intensive. You're probably thinking, wow, 12 sessions over 18 weeks, that's quite a lot. And that's something that we're reflecting on now about the dosage. But this is what we provided in the trial. We followed people up a lot, but our primary time point was 18 weeks. So the trial the primary outcome, the treatments had to be completed, and our main outcome was pain intensity, because the theory behind this was we should be changing pain. But we also measured a suite of secondary outcomes which were identified as being important to the people with chronic low back pain. So let's talk about the intervention. So I've got the 3 pillars here. We've introduced you to those. You should be familiar with them. We can chant them out now. Understand, refine, load. That's what we're trying to achieve with this intervention. And to do that, we had 4 key components we tried to service these targets. And they are, yes, it works. They are provided here in the table. Now, the table is a long way away, so I'm going to talk you through it on multiple slides. But if you've got really good eyesight and you're extra interested, and those online, on this first column is the intervention component. So we had a discussion of your low back pain experience, we had graded sensory training, graded motor imagery, and a movement training component. And within some of these components, there were smaller features. So within sensory training, we had localization, discrimination, and graphesthesia. So you can appreciate one component, multiple subcomponents. And in these columns, we have the session number, so 1 session all the way up to session 12. And the coloured component reflects how much of that session was given weighting to that part of the intervention. So you're starting to get the idea. So first session was all about discussing the person's low back pain experience, giving them the floor, understanding their story, and starting to see where we could work together and introduce the treatment program. Then we gradually introduced elements and then gradually phased them out as the person progressed through the program. So for the understand pillar, this was, as I described, additionally quite heavy at the start to get the key concepts across, then kind of tape it out towards the 12th session to be more reflective and more of a way to trouble solve challenges in understanding these concepts. And really it was built upon the Explain Pain sort of curriculum. This was an older version of pain science education. I think Explain Pain was published, the last version around 2015, 2016. So it was kind of an older model, but still probably more contemporary than some. And we used a combination of reading, of watching videos, listening to podcasts, different metaphors and analogies to try and make sense of these concepts. We really tried to have the different mediums to play to different people's learning strategies, but also to reinforce from different perspectives. And anecdotally, the participants found that really useful. So I could introduce a concept and then go home and watch our lovely David Butler explain the exact same concept in his words. And that really gave legitimacy to the idea that we were trying to convey. The feel safe to move, the refine pillar, had those 2 different main components, graded sensory training and graded motor imagery. A video's playing, so I'll talk to, oh, it's gone, it's too quick. Oh, no, there it goes. So on this screen here, you can see a video of a participant laying on their back. There is a picture of the back, on top of their back. There's all these dots drawn on them. We don't encourage dots to be drawn, but anyway, there's dots to be drawn on them. And then there's some person behind the camera with a poking stick. So this was an activity called localization training. So the idea was the person would get touched on the back according to a grid that both the clinician and the participant could see. And they were asked to locate, well, whereabouts on the grid are you being touched? Is it 1? Is it 3? Etc. And the person would respond, and if they were correct, would say, you beauty, move on to the next one. If they were incorrect, we'd orientate them. No, that was a 5, this is a 3, or whatever it would be, to give them immediate feedback to try and help them with their task. So that was localization. It was then progressed to discrimination, where we had the same task but with a sharp and a dull end, and their job was a bit more complicated, work out where are you being touched and with what stimuli. And that was progressed as grids got smaller, the same as the last one. And finally, we also had a graphesthesia component where we drew letters, words eventually, numbers and sums on people's backs as increasing complexity to help them orientate to where they were being touched in space. These were the graded sensory training components. And you're probably starting to think, that's where that person came in, the trusted person. So in order for the person to complete this homework task, they needed a poker or a drawer. So they had to have that person to get into the trial. So that's just a fun fact. We had the graded motor imagery was the next component, which was supposed to also support the refine pillar, which involved left-right recognition using the Recognise app from NOI, as well as a series of motor imagery tasks where we'd get the participant to watch videos of other people moving their backs. Starts off being small localised movements towards more progressive multi-body movements to more functional tasks. And the person was required to first just appreciate the fluidity and the comfortableness of the movement and the safety and power of these positions, and then eventually progress towards them imagine themselves performing these tasks. And this progressed over the first course of the program to get to more challenging and get the person feeling like it's safe and ready for them to move. This was also a really useful part of the therapy for the person to sit next to the therapist, and the therapist could use these videos as tools to reinforce some of the educational concepts. So the person's reactions while they're watching these videos often served as opportunities to reinforce key nuggets or key concepts about an overprotective system that's trying to needs to be changed. And last, we had this experienced safety of movement. I won't go into great detail here because it's a broadly physical therapy-based audience, but it's just a progressive movement training component. The novelty of it was that it focused on first mastering smooth, fluent movements of a really small area to progress into more part practice to eventually more functional, complex practice. The novelty really came from the feedback. So Ben loves words, graded precision, focused, feedback-enriched functional movement training. The real novelty here is this feedback-enriched environment. It wasn't just feedback from the therapist saying, yeah, that's about right. We had visual feedback with the use of mirrors. So mirrors were placed around the clinic so the person could see their back, which is something we don't ever really get to see. And that was really quite powerful for the participants as they progressed through movement training to see their back moving and actually see how powerful and robust and built to move it was. So that was the intervention. It was somewhat complicated, you can appreciate that, but when you get the hang of things, it actually kind of flowed quite nicely. But we really wanted to develop a sham which accounted for some of the features of this intervention, to know that if we saw an effect from this trial, it was driven by the intervention itself, not just the act of going to a shiny research institute, spending 12 sessions with a really chatty and polite therapist, as well as progressing through greater components of the intervention. So that's exactly what we did. We matched for all those features, and in order to match for having different interventions and different interventions which may target the brain, we had detuned electrotherapy-based tools. So we used, detuned transcranial direct current stimulation. So it was sham mode, it was turned off. We used low-level laser therapy, it was turned off. We used pulse electromagnetic energy, it was turned off. They looked real, it was quite impressive machines, but they were off. And then we developed a cranial electrical stimulator to account for homework. This was a TENS machine we pulled the back out of, plugged in earbuds with like little clips, and the participants would wear them for 30 minutes 5 times a week. They really liked these tools. A lot of people wanted to keep them. We had a hard job trying to get them back, but that was what we did. So that was a sham. It's quite complicated. It's described as a sham and attentional control in the paper, and that's essentially what it did. But the question really was, is that actually a credible intervention? Because it was a little bit weird, a little bit complicated. Do people buy it? So we formally tested this with the credibility and expectancy questionnaire, and there was no difference. So that was reassuring. but we really kind of had a sense that it was already. And I put a picture of a bottle of wine here because often the PI, James McCauley on the grant, would get a little bit concerned because in the sham therapist room, there'd be boxes of chocolates and bottles of wine and all these presents. And in the treating therapist rooms, there'd be nothing. So he was starting to get really worried that something was going wrong and maybe that was too good of a sham. But we'll get into the participant flow. So this was your standard flow chart of participants. We screened over 1,500 people and randomised 276. We lost a lot because they couldn't get to Sydney. We lost a fair few because they had no loved one or supporting person to do the home training with. The main reason I want to show this flow chart is just to highlight that we had really good follow-up. Most trials, particularly of behavioural interventions, have between 15 to 20% loss to follow-up. We only had 5, which is really quite impressive, and primarily because we had some strong work in research assistants who were really making sure that we got the data so we could be more confident in our results. These are just the baseline characteristics of the people who were included in the trial. Generally, they look like the sort of people you would see in primary care. Pain intensity of around almost 6 out of 10, back-specific disability around 10-ish on the 0 to 24 Roland-Morris scale. But the main thing to pay attention to is that they had back pain for a long time. So around 5 years was the median. So that's really, I guess, quite true of the sort of people you see if you're seeing chronic low back pain. So this is the money slide. This is the results for the primary outcome, pain intensity. I'll talk you through the figure. So this is the box and whisker plot where on this axis is our 0 to 10 pain scale. On the bottom axis we have time at baseline 0 weeks, 18 weeks, all the way up to 1 year. The blue is the intervention arm, the yellow boxes are the control arm, the dots in the middle are the means, and the lines are the medians. The main thing really to pay attention to is that we did find, I lost my swirler, that's all right. We did find a difference at our primary endpoint of 1 point on a 0 to 10 NRS, which is considered prior to doing the trial and considered in the community as being a small to moderate effect. But the really exciting thing was that effect was sustained up to 6 months and then started to dissipate by a year's time, 52 weeks. For disability, we saw the same. So this time we had the 0 to 24 Roland-Morris on the axis. Everything else is the same. And we saw a 2.5 point difference between groups at our 18 week. But the really cool thing about disability, and you can see quite nicely with these sort of presentations, is the blue group stayed consistently low the whole time compared to the yellow, and they stayed significantly different the whole way up to 1 year. So this treatment seemed to provide sustained reductions in back-specific disability compared to the control, our attention-matched sham. And if you look at the medians, which are the lines at that, at the 52-week line, the middle, it's around 1 point. So this is looking like, well, maybe this is something which is quite exciting, quite interesting. But this is one trial, and we need to talk about other things first. When we look at the secondary results, so these are the secondary outcomes, we see the same sort of effects. We see quite small to moderate differences across all outcomes except for depressive symptoms and insomnia, but it kind of makes sense. I'll go through it in a moment. The main thing we were quite interested in is our recovery outcome. So we define recovery being a person reporting 1 or less on a 0 to 10 scale at both 18 weeks and at 26 weeks, up to 6 months. And you're twice as likely to be recovered in the intervention group compared to the sham group. So this seemed to be something interesting anyway. But that was enough. We saw that it seemed to work. It seemed to have sustained effects on most to all outcomes. But we built this intervention from the ground up from quite a large theoretical model. So we wanted to know, well, did it actually change those outcomes through the targets we thought it was supposed to change? So we conducted a mediation analysis to explore this, to answer the question, how did the intervention reduce pain and disability? So essentially the goal was, we know we had an intervention, we know it changed this. Did it cause that change by going through understanding, refining and loading? So in order to try and get at that question, we had these 7 mediators. So we had tactile acuity to try and address some of the sensory training, motor coordination to try and address some of the movement component. We had a back perception to try and address some of the perceptual changes, beliefs about back, fear of movement, confidence in the ability to do things while in pain, and some pain-related worry sort of things thrown in the mix. I'll orientate you to the results and I'll show you disability because it's the same sort of representation. So up here is pain intensity on a 0 to 10, and that's the effect that we're explaining. On this axis is each of the different mediators, and along the bottom is the indirect effect. So this is on the same scale, on that 0 to 10 scale, and it can be interpreted as essentially the effect on the outcome if it went solely through that mediator. Does that make sense? So it's the effect of graded sensorimotor training on pain if it just changed back beliefs or if it just changed motor coordination. Anything to the left of that dotted line is a mediator that had an effect. Anything on the line or to the right we're not as excited about. But really it's quite clear if you look at this, everything that's moved to the left a long way are these three things. And the real key winner here looks to be back beliefs. If you change someone's back beliefs or changes of someone's back beliefs induced by the intervention seem to actually explain most of the effect that we saw in pain. And really it's the exact same result for disability. Maybe a little bit more of a role for kinesiophobia, but otherwise it's the same sort of thing. So our takeaway from this was really the key thing this intervention worked was by changing reconceptualizations of someone's problem, changing someone's belief, but also some roles of changing pain-related worry and increasing our confidence to move. But these seem to be key treatment targets for this intervention, and anecdotally, these seem to be key treatment targets for most non-pharmacological interventions for back pain. We also wanted to explore the patient's or participant's perspective of the intervention, and we did this through a qualitative analysis of people from within the trial, and this was led by Dr. Rodrigo Rizzo from our lab, and he really wanted to explore the experience of the trial participants and identifying facilitators and barriers to the acceptability of the intervention. So he used semi-structured interviews with a purposive sample of participants who completed the intervention, and he wanted to know really from people who did well, but also people who didn't do well, because that was equally important to help us understand what people thought of the intervention. And he used a thematic analysis orientated around a framework, and he used both inductive and inductive coding. So he identified 9 positive facilitators and 7 negative barriers of responses towards this intervention, which he was able to map across this framework. And I'm not going to go into great detail because I don't have a lot of time, but the real thing that we found was overall, most people thought it was acceptable. The key takeaway though was the reason they thought it was acceptable and the reason they thought it worked was this combination of reconceptualizing their problem, but also being provided with behavioural change techniques which helped shift them to a state where they thought they had permission to move. And that seemed to be this key message that we got from the data was they felt like they had permission to move and then they did it. And we hear this actually from a lot of back pain qualitative research. This is something that people are wanting to get. And I guess the way we provide it was with quite a complex way. Maybe there's other ways or better ways, but nevertheless, that was one of the key features that they found useful. There were some things they didn't find particularly helpful, they thought would be challenging for us moving forward. One of the things that really stood out was this idea we needed to reinforce that pain is real. So we had 12 sessions, one-on-one for an hour, trying to get at this complexity of pain and the pain experience. Yet participants still felt at times that we could have spent more time talking about how real it was as an experience. So I think this is a challenge for us if we want to go down this route or continue to pursue this route, is making sure that we get this message across, because this is a critical message that people need to hear. They also wish we spoke more about the pathanatomical considerations of the spine. We kind of avoided talking too much about anatomy, but they wish we spoke about it more. And they wanted some more support for long-term self-management. We removed resources, not intentively, but because we cut off their access to our online platform. So they wish they had things to keep them going, maybe a book or a podcast, or at least something they could have taken away and reflected on in the future if they had a flare-up. So that's something we're thinking about moving forward. So to summarise, we think it was somewhat of a rigorous test. We don't often see sham-controlled trials. This was one that was large and well conducted, and it seemed that the intervention was able to provide some meaningful changes on key outcomes, which was sustained over time, which was, I guess, a unique insight for this intervention. Our mediation analysis suggested that really it supports our model, but also this idea that reconceptualising our beliefs about the problem is actually probably a key target. It's something we should focus more energy on. Our qualitative analysis suggests that the intervention was considered acceptable by the participants, and they really prioritised this combination of reconceptualizing the problem, but also getting to experience things to give them permission to move. So we're really trying to take this information on board when we're thinking about the next steps with this intervention. But it's an exciting time for back pain because we were a little bit excited. This is one treatment which has shown promising and sustained results on some key patient outcomes, but it's not the only one. In the last 3 years, we've seen pain reprocessing therapy coming out of here from the US, from Yoni Asho's group. We have this cognitive functional therapy coming also out from Sydney, from Peter Kent and Mark Hancock and Peter O'Sullivan. And you can see here all of these have this commonality of persistent effects over time and effects which are considered within their boundaries or their thresholds as being meaningful. And it's the same sort of story here for disability. The challenging thing is these are all published in different journals, we have different formats, so we're trying to look at these pictures. We've got a box plot, we've got column. It's just really tricky to look at it, how they go together. So Lorimer has been great and he's put them all onto one slide of the common axis. So this is each of the intervention arms, not the control groups, on the same common pain axis. So we have cognitive functional therapy here, we have resolve or graded sensorimotor retraining, and we have pain reprocessing therapy here. You can see here that people in the pain reprocessing therapy looked a little bit different. They had quite less pain than the other two groups. But I guess the focus I want to take here is this is a good news story, I think, possibly for back pain. We haven't cured back pain, I'm definitely not saying that, but we've found interventions which are providing reductions which are sustained over time. So I think this is a good start for the field and something that we can work as a team together to try and refine further so we can get these lines a lot lower, but continue that sustained momentum. So why do we think that these trials are really quite important, but also something that we should be a little bit enthusiastic about? I guess each of these interventions were developed from the ground up, identified from problems that that been seen in the literature for people with chronic low back pain, as opposed to some other interventions which have just been translated across from depression, try to translate to pain, or from, we can go on. So this is something which we think is quite unique, but also really quite promising. They all try to get at this idea of reconceptualizing the problem of back pain. They all do it slightly differently, different ways, different contacts with therapists, different tools, different targets, but nevertheless they're able to achieve their outcome and produce sustained changes. So there seems to be something in this. The trick, I think, will be is to work out what's the best way to do that now. How can we combine efforts, or what should we be thinking about? And lastly, we found that from the 2 studies which published mechanism evaluations of how the trial worked, it seems that achieving this aim, reconceptualising the problem, actually explains most of the effect that we've seen. We've removed the CFT trial here because theirs isn't published, but it will be coming soon, so I think we should look forward to seeing what that shows. So what are the next steps for us? In terms of graded sensorimotor retraining, we've done one test of an intervention to progress through a slow research pipeline, but it was in quite a unique setting. So our next step is to see, well, can we put this in a clinical setting? Can we train clinicians to provide this intervention with real patients rather than just people who are attending a fancy neuroscience research institute? And this year we've received funding from the Australian government to conduct, we call it Resolved, but everyone calls it Resolve D, and I find it anyway, a new randomised controlled trial trying to look at more of the implementation components of this intervention. So this is going to be a more pragmatic trial where we're testing this intervention against usual care in usual clinical practice to see if that's a feasible and an appropriate way. And we really want to see, does it work? Does the effects, are they still there? Is it something we should be interested in? But also, is it implementable? Can clinicians provide this intervention in clinical practice? Maybe, maybe not. What are the gaps? What are the challenges for that? Is it a systems level challenge? Is it a training level challenge? We want to learn this so we can, if it is effective, can make sure that we can get it out and get it going. And we're partnering with some key players to help make this possible. So we've partnered with Noi Group on the grant. It was a co-partnering fundeship grant. So they're going to help us support the training component, how we can train clinicians. They've got infrastructure and resources. We've partnered with UNSW and Neuroscience Research Australia to make sure with the research background to make sure we can get this to happen. So something to be coming in the future and something that could be quite exciting, we think, but we've only just got funding and it will start eventually. But broader applications, so we've focused on the fit for purpose model as like a biggest way to make sense of chronic back pain. How do we tie into all these different interacting components? And we've applied it to one intervention, graded sensorimotor retraining, but that maybe isn't the best way to do it. Maybe it is, maybe it's not. We're not really sure. But can we try and achieve that goal of reconceptualizing pain within a fit-for-purpose model perspective using a different strategy? So we're testing that at the moment in 2 different trials. So we've got one trial, we always have funny names for trials, so don't ask me why they are called that. We have one trial called the NOTICE trial, which is taking graded sensorimotor retraining and putting it into an app so that it can be a self-managed intervention conducted by the person in their own time. And to support some of those experiential learning components, we've teamed up with Rodrigo Rizzo, who's in our group, who's an experienced in clinical hypnosis. It's going to have a hypnosis component in it as well to try and reinforce some of the educational learnings and provide experiences to get things moving. So that's the NOTICE trial, which is currently funded and underway. We have another trial called Capacity, which is trying to target a more left out group in low back pain research. Often we see people who have multiple cardiovascular or chronic disease risk factors removed from clinical trials. So we're trying to specifically target those and make sure our educational offerings support a more holistic view on health and their recovery. So we have another trial which is more of a coaching style version of graded sensorimotor training. It's stripped back to its coaching elements and focusing on that reconceptualization pillar. We've extended it to to neck pain, so we have another trial called Reconnect, which is led by Tash at the moment and Felicity, so I'm sure they'll be talking about that in the coming years. And we've also tried to shift it across chronic conditions. So you imagine back pain to neck pain is not a big stretch, it's kind of quite close. We're also applying this framework with other existing tools for complex regional pain syndrome, which is the Memoir trial, which is currently running, and for people with phantom limb pain, which we've called the Titan trial. It's really trying to say, can we use this broad pillars of understand, refine, and load, or to move back to meaningful life and meaningful activity? Can that be applied in a way which helps them reconceptualize their problem and get back to doing the things that they want and need to do? And how do we do that? What's the best way? And we're trying to test that in these different trials and for different populations. So I'm doing all right for time. I'm happy with that. So just to finish up, there's a lot of people who have contributed to the research. Not everyone's mentioned here. Every time I use this slide, more and more of the students have had their doctorates confirmed, which is really quite fun when you type in new initials. But mainly want to draw it out. Professor James McCauley is my Ph.D. supervisor and continues to be my mentor. Professor Ben Wand and Professor Laura Mosley, who have really built the fit-for-purpose model. This is from their clinical and experimental data from the last 15 to 20 years, so they really deserve mention. So that's it from me. Thank you for staying to the end. You've done fabulous. I look forward to questions or a chat over with a beer. But if you want to reach out, particularly those online, that's my email address, X or Twitter. So yeah, thank you very much.
All right. Oh, we got hands already. I'm going behind you first.
Aidan, thank you so much. Your results it's really impressive and hopeful. I'm going to step out of my lane a little bit, and I want to ask you about the methodology of the GSR study. I'm just curious if you had thought about doing or having a full control group where to maybe account for some of the non-specific effects, why or why not, and then secondarily, it's a fairly extensive approach, and I'm just wondering, in the future, are you going to look to see are all of those components necessary or not?
Yeah, great question. Thank you for that. The second one's my most favourite because we've been toying with this for a while, but the first one is a critical question that we always have when we're thinking about a trial and it gets funded and making sure we have the right comparator. For this one, the first trial, we thought that a sham or a placebo-based model made the most sense in terms of we really have little data to support it as a framework we should push into primary care or into care. So we wanted to know, does it work better than removing the non-specific effects and the placebo effects associated with interactions with therapists? So that was why we chose that as a first point of call. Our next thought is to try get into more pragmatic settings. So we're thinking a usual care control group is our best way to compare it to the existing literature. as well as for us to make policy and practice decisions within our setting. But all these control groups are challenging and are fraught with benefits and cons. The second question about the intervention complexity is a real concern that we have. It's 12 sessions, which are 1 hour, which doesn't really fit any funding models that we have in Australia. I'm not sure what it would be like in the US, but currently it would not fit. So that's something we are working on. So our next iteration we test in the Resolve trial will be a shortened version of this. So we've got focus groups planned with NOI clinicians, with clinicians in the wild, clinicians who are practicing and doing things as experts as they are, with people with lived experience, and with insurers and policymakers to present our framework and say, well, would this work? And get their feedback and try and refine it somewhat. And that may be compromised. That may be compromised in terms of how many sessions we provide, maybe compromised in components, get moved online or get scratched. But at the moment, we're thinking everything needs to stay in there, but we need to do it in a way which is going to fit health systems. Because there's no point us developing an intervention that no one can do. It's fun, but it's not particularly useful of anyone's time. So yeah, it's a great consideration.
All right, other questions? Anything online?
First, thank you for doing this incredible research. I've only seen a little bit about the Resolve trial so far and haven't dove into it, but learning about it here today was light bulbs going off in my head. And I especially like that you had permission to move up there, because I've lost count of how many patients I've seen where they regained that permission to move, or they articulated that in those exact words. I've got that permission back. You gave me permission to move, or some variation on that theme. Even after just the consult visit, they come back the next week for their follow-up, and it's like, my back pain is like a 0.5 now, where it was a 7 when I did the consult. And I'm like, what changed? I'm not afraid of moving now. And I can't take credit for that kind of stuff. That's the patient, doing that internal work, that's some of that soul searching, racking their brain over, is this something I really need to be obsessed over to the point where it causes me distress? So it's really good to see that addressing more of the psycho-emotional side of things and how we perceive ourselves and our pain is having a really tangible effect.
Yeah, thank you for your comment, and I agree that this idea of permission to move is a really challenging one, because it's not just like this. You can't just tell someone it's okay. You have permission to move, and it's not just them being able to say it. It's like a deeper internal recognition of that they have permission to move. And I think we can help the person get to that journey through the tools we provide, the way we present ourselves, the way we frame information, and the strategies we put them along on their journey. But I think there's different ways to do it. When you hear reflections from clinicians and from people who've experienced this and recovered of how they got to where they are, I think the challenge is working out what is the best way to harness that and put that into an intervention which is going to apply for most people. Won't be everyone, but for most people. So we've gone a long way around to get to a package. So the next test will be, how can we do that easier? But yeah, I appreciate your comment.
Question from online. Was the follow-up time of 1 year chosen primarily due to design, funding, or other factors? And that's considering data that shows a high percentage of surgical patients regress to original status within 3 years.
Yeah, great question. So it was purely a pragmatic choice in terms of funding to follow people up. One opportunity we missed out on with this current trial was not putting into our ethics to allow future follow-ups. So our future trials are now going to include a 3 and a 5 year follow-up. We expect drop-off to be, or missing data to be actually a lot higher, because it's challenging for someone to stay engaged, or they might change numbers or whatever modes of contact, but that's a plan moving forward. Because we want to know, does this have sustained changes beyond that 1 year being in contact? So it's a great consideration.
Thanks, Aidan. Just touching on the key takeaway message of needing to reinforce that pain is real. What do you feel were some of the factors that led to people feeling as though the clinician thought the pain was not real, and also maybe some helpful ways for that clinician to validate their experience? What are your thoughts?
Yeah, no, great question. And this idea of pain isn't real, when it came out of the qualitative interviews, was broader than just the clinician not providing the person with that opportunities. It was also a societal view. So the participants found it really challenging initially to explain to their partners, their friends, their colleagues about what the intervention was trying to do. And they felt that, this was one of the quotes, that this is like an uphill battle for us, trying to push this forward in like a health system which is pushing the completely opposite direction. So I think a part of it was the clinicians could do better. I think we could spend more time focusing on the person in front of them, titrating the education towards their lived experience, and continually checking in with them to make sure we're hitting the right levels. In a protocolized intervention, you can lose some of those important skills because you're really trying to make sure you don't miss things. I think there's opportunities for clinician improvement. But yeah, I think these are tough concepts in a society which views it quite differently. So that's a part of the challenge as well that we're seeing.
Aidan, well done. Thanks, mate. Not unrelated to your answer then to that, are there any other components of the trial that you felt might have been underpowered by, just the nature of the time frame that you had for implementing certain components? I noticed the tactile acuity section didn't seem to, it's not irrelevant, but it, potentially was underpowered. Is it, about patient selection, or is it about not enough stimulus? And equally, regarding exercise, is there anything that you saw through the trial that was, underdosed or not patient-centred? Or
No, great questions. The tactile acuity is a really fun point. I'm glad you brought it up. Because when we saw the mediation data come through, the one component which didn't allow people to enter the trial and was actually one of the biggest bears or burdens for homework was the sensory training. So when we saw that it didn't have an effect, I was like, you beauty, get rid of that for the next version. But the problem was from the qualitative data and talking to people during the intervention was that the sensory training was a way of reinforcing these educational targets that their nervous system has changed and it's changeable. They can train it, they did train it and they got better. Whether it got pain better by changing things in the brain, sensory maps or whatever it is, maybe not. Maybe our measure of that tactile acuity wasn't particularly good, but maybe it worked through other pathways. And that was a real challenging thing we have for us at the moment. So we're not keen to kick anything out because it may work through other paths. And we think reinforcing the educational learnings and this concept that they have changed and they can change again is critical. For the exercise component, it was really structured on getting them moving again, getting them feel safe and confident to move, and then shifting towards doing things important to them. And it wasn't dosed in terms of challenging heart rate or really trying to stress muscles or target load-based principles. It was really based on, it was almost like graded exposure towards meaningful activities. So we didn't have that, but we have thought about maybe there is a heavier loading component required when they get to the next step, but that wasn't integrated in this current iteration. Yeah.
It's fascinating trying to have people in pain reconceptualize what that pain is. And I know that you had mentioned that one of the things the participants mentioned they would have liked more information on was like more information about the spine. Can you give me that? Was it an accidental, or was it an intentional thing of like, hey, if I know things more about my spine, I can then blame this facet joint at L17 because that's the reason for all of it?
Yeah, no, it's a great question. We intentionally tried not to talk too much about or go too much into the pathoanatomical stuff around the back, and particularly some of the misconceptions around associations between changes that are seen in, say, scans, for example, and the pain experience that people are having. But people really wanted more of that in order for them to feel safe and assessed. So that was the real takeaway for us. James McCauley's bias, he's a psychologist by clinical training, and he was overseeing a lot of the initial assessment, and that was really, let's take that out and focus on the person and their story, and let's not get too excited about, can you move this way, this way. But the people who were presented to care, they wanted that. They wanted to have a thorough assessment to feel safe and hear some of those features explained. So our future iterations are going to include a thorough assessment, which may involve a physical component, even though we didn't last time. But we tried to avoid, those sort of things coming up. But thank you.
Not very attached to
Yeah.
This is what it is.
Yeah.
And sometimes that slows things down because an image shows a picture.
Yeah.
Not a living experience.
Yeah, and one comment I just want to add to, because I agree that challenge of reconceptualizing something is really hard, but often we could see incongruence with the belief that they have. So we could draw into their lived experience to find examples of where their belief didn't actually match what they'd experienced in life, and that shift became a lot easier. And we were lucky to have 12 one-hour sessions so we could learn that person's story, understand intently why they thought the way they did, then try to draw out those experiences to shift it. But it's a hard thing, and I don't think it's achievable in 5 minutes necessarily, or a couple of short consults. You're welcome.
I used to be a chronic pain patient, and from head to toe I had a lot of different things going on. And the therapists that I saw several different types of therapists, and they were able to get things moving in the right direction. And at the time, I don't think that any of them were really aware of pain science. I mean, we're talking quite a while ago. But both of them did avoid using language that would increase catastrophization and so forth. So they were actually kind of inadvertently using a similar type of approach. But none of them were working with me on exercise, because I was one of those do-it-yourselfer guys. And so as I started to have less pain, they encouraged me, like, okay, if you think you can handle more activity, see what you could do. And I would try some things, and it would hurt more. And so I started looking like, okay, is there some program that I could get like on a DVD and just follow that? And I found that there were, and I tried a couple of different things, and I found one that my body tolerated it well, and I kept working my way through it. And one of the things that really struck a chord with me as you were talking is that thinking back about that DVD, I mean, the whole time that, throughout that whole DVD, the person presenting it was like, we're just going to go through some different movements, go as slow as you need to, make the movements as small as you need to. We're going to start with some really simple movements. And if it starts to get to be too easy, you could go try to make the movements a little bigger or a little bit faster. I mean, so they weren't talking about pain neuroscience education, but really just kind of shifting the focus to listening to your body and giving you kind of a structured approach to explore your capacity to move. And then they kind of stepped it up in terms of like, okay, if you can handle the simple version, let's try a more complex version. And so it was, again, very similar to this, but structured differently, because the person presenting it was not at all aware of pain neuroscience education. So it's kind of, I'm very excited to see how this goes, because I can see something like this being adapted for use within personal training, which would give us tens of thousands more potential providers that could provide support, this type of support, without having to exceed their scope of practice.
Yeah, well, thank you for your comment and sharing your experience. I think my takeaway from that, and I really liked how you described that graded movement experience and progression. I think we have very similar themes, I agree, in this intervention. There was a focus on feedback and precision, which tried to reiterate this idea of regaining control or changing that key pillar. But yeah, I totally agree. I think it's important to see how this could be scaled and whether it could change across different professions. At the moment, we had physiotherapists and exercise physiologists working on the trial, but for our next one, we're thinking of definitely expanding the therapist pool, and eventually, once we can work out legal things, it could be other therapies. So yeah, thank you for sharing.
All right, I think that's it. Thank you so much, Aidan.